Hi, this is Brian Kim. I'm going to share with you this case of a patient who had cataract surgery with me many years ago. She actually presented with severe anterior uveitis, posterior synechiae, secluded pupil. And so I did a posterior synechiolisis. I was able to retract the pupil with iris hooks, place trypan blue, remove the cataract. Later on, she developed severe capsule phimosis, and I had to YAG the anterior capsule rim to be able to release that phimosis. Again, this patient with severe uveitis. I didn't see her for many years. She's from out of town, and she presents later on with this appearance in my clinic. You can see there's significant dislocation of the capsular bag and the lens. She has a single piece of acrylic lens in the bag. You can see the peripheral capsule edge here and loss of zonules as well. So I'm going to have to take this lens out and replace it with a Yamane technique. So first things first, I always like to dry the surface of the eye before I get started. This is the right eye. You can see I'm sitting supero-temporally. I have the narrow wire speculum, which gives me more real estate to work with in the superior and inferior areas of the sclera. I marked the limbus on the right side with a 25 gauge cannula, and then finding 180 degrees apart, I'm marking the other side on the left side as well. This is a fixed caliper from Epsilon. I have no financial interest. I'm indenting the sclera 2.5 millimeters posterior to the limbal mark and then 2 millimeters adjacent. I'm going to ink those limbal indentations with the 27 gauge cannula, again, that my technician inked. And I'm going to do the same thing on the other side in similar fashion. Again, the fixed caliper indenting 2.5 millimeters posterior to the limbus and then 2 millimeters adjacent. That indentation shows up as a dark spot, and then I'm able to ink it with the tip of the cannula. Nice and small, discrete marks for the Yamane technique. This is the back of the trocar. This is 4 millimeter trocar. I'm indenting 3.5 millimeters posterior to the limbus, and then using a cotton tip, which is better at controlling the eye, I'm going to tunnel about 3 millimeters tangentially towards that indentation I made, and then I dive down perpendicular. You can see that the trocar cannula is sitting sideways, which means hopefully it'll be a self-sealing sclerotomy. I'm making my incisions first on the right side and then the left side. This is the incision for my anterior chamber maintainer. And then the contralateral incision is to externalize a leading haptic for my modified Yamane technique. Injecting some intracameral epinephrine, very gentle that I don't overinflate, and then pushing dispersive viscoelastic to coat the corneal endothelium. Using that cannula to control the eye, I make my 3 millimeter incision. I make a vertical groove, tunnel through the cornea, and then I enter. Using the assistance of the vitrector, I go through the pars plana trocar. I lift the lens up and then grab it with microforceps on the left side. Take the vitrector out, switch it with another forceps. And then with two hands, I'm able to re-grab and pop the entire capsular bag, sweeping the iris so that I can pop the entire lens bag complex into the anterior chamber. Holding with the left hand using the IOL holder, I'm able to cut with the micro scissors in my right hand. I cut about 90% and then perform a Pac-Man technique. The single piece acrylic lenses are fairly easy to grasp and pull, even with the smooth forceps. Pulling the right side piece out first, stabilizing the left side piece with the other forceps. Once I have the first piece out, I let go on the left side and then rotate that lens piece out to get the second half out of the eye. And it's nice to do the Pac-Man technique so you don't lose a lens, but it also, you can see that the lens bag complex, and that some rings ring capsular bag material is also with it. I push some viscoelastic, increase the intracameral pressure, and then I burp the lens material out. You can see here I'm using a wax cell to check the wound, and there is no vitreous at the wound. It's been my long theory that these cases with late dislocation is associated with liquefied vitreous, and so vitrectomy is still important, but I've noticed a lot of times there's just no vitreous to the wound. This is a 22 gauge thin-walled AC maintainer. Again, I don't have any financial interest, and this is the vitrectomy, removing any potential vitreous in the anterior vitreous space through the pars plana incision and then through a limbal incision. This is a 25 gauge needle. I'm bending it fairly close to the hub, bending it so that the bevel faces to the right. This is a right side 30 gauge thin wall needle. I'm bending it about 9 millimeters from the tip and then bending it in such a way that the bevel will face the main incision. And this is the left side needle bending at the hub, making sure that the bevel faces through the contralateral limbal incision. Again, all of those needles are mounted with BSS so that there are no bubbles with the intraocular maneuvers. This is the emerald cartridge. Push some cohesive viscoelastic within the barrel and on the platform, pushing the Sensor AR40 lens within the platform. You see I'm doing the little side-to-side shimmy, making sure it's seated down, making sure the optic bends backwards. The leading haptic comes out straight to the barrel and the trailing haptic comes out to the back end. As I place it into the injector, you can see that the trailing haptic is out and above the barrel so that when I place the plunger through, it doesn't damage the trailing haptic. Placing the 25 gauge needle through the contralateral limbal incision, advancing the lens. Both bevels are facing each other with the assistance of my surgical technician. She advances the lens. I dock the haptic on the bevel of the needle. She keeps advancing the lens and more of that haptic is internalized into the needle. And then I pull the needle out and the leading haptic is out of the eye. I take over, make sure the optic is delivered planar and the trailing haptic is swept to the right. You want to let the optic slowly open on its own. Turning off infusion and then pushing dispersive viscoelastic to push the optic back, as well as recoat the corneal endothelium. Okay, I'm trying to move the AC maintainer out of the way so I can get the needle in position. And then I'm going to grab with 0.12 forceps, grasping the trocar cannula, turning on infusion, stabbing the conjunctiva and sclera at the first mark, making sure I'm in the right position, making sure that the conjunctival marks are perpendicular, stabbing, and then flattening 2 millimeters. You want to stay essentially parallel to the scleral surface, tunnel 2 millimeters, and then I dive down towards the nerve, rotate the needle into view, pulling the leading haptic out of the eye more to push the optic away. This gives me a lot of room to visualize cannulation of the trailing haptic through the right side needle. And you can see I just flatten it out, 2 pushes, and then I'm in. Disengage the needle from the syringe. Internalize the leading haptic, placing it into the angle. I'm going to hold the contralateral limbal incision with forceps. By having counter traction, you're able to stabilize the eye in the neutral position so the conjunctival marks don't move. I'm trying to stab through the conjunctiva and sclera. I don't feel quite comfortable because I can see the conjunctival marks are moving as I do the maneuver, so I stop. I start over. I'm going to stab through the conjunctiva and sclera at the first mark, tunnel 2 millimeters. You can see that the eye started to collapse. And why is that? And that's because my AC maintainer came out. So rather than going forward and with a high potential that the lens position is not going to be right on the left side, because I had scleral collapse because the AC maintainer came out, as you saw, I'm just going to start over again. So hold the eye contra-incisionally, High infusion pressure, stabbing through the concha and sclera, tunneling 2 millimeters, staying nice and flat to the sclera, and then I dive down. Much better execution of that part of the surgery. Why? Because I have infusion. So again, if I lost infusion, the eye collapsed, just start over. It's not a big deal. You haven't lost anything. So I dock the haptic on the bevel of the needle, 2 pushes, and then I'm in. Again, 2 pushes is all you need for the Sensar lens because the 30 gauge thin-walled needle grips the Sensar AR40 haptic so well, you don't have to internalize too much of the haptic in the needle. And if you internalize too much haptic into the needle, you're going to cause undue stress on the optic-haptic junction. I pulled the left side needle out, limiting how much haptic is externalized. I cauterize the tip. And I perform the same thing. Again, as I withdraw the needle on the right side, you're going to see that I'm going to continue to push the haptic into the eye to minimize any exposure of the haptic outside the eye. By doing it this way and limiting how much haptic comes out of the eye, I'm able to limit any undue stress on the contralateral optic-haptic junction. This minimizes any undue stress on the haptics throughout the entire procedure using my modified Yamane technique with all of these steps. Pushing the haptic flush to the sclera and burying the flange and reapproximating the conjunctiva. And now this is the surgical PI. This is with a low flow setting and a fixed low cut rate, turning the port down, making sure that the PI is about the position you would want for a laser PI. Again, you're not all the way into the angle because you might accidentally eat the ciliary body and cause a significant hemorrhage. Go ahead and perform anterior vitrectomy now through the pars plana. And then I'm going to pulse BSS with the BSS cannula. And by pulsing the anterior chamber with the BSS, it loosens up that vitreous that's coating the cornea. This is a 10-0 nylon suture. I always close my main incision. Turn on infusion, take the trocar cannula out, massage the sclerotomy, hoping that it's self-sealing, turning on infusion, feeling the firmness of the globe, taking the AC maintainer out, and then I'll hydrate my incisions. So again, this is a patient who had a complex cataract surgery, anterior uveitis, posterior synechiae, secluded pupil. I had to lyse the synechiae off the iris. She had a small pupil. I had to place iris hooks, trypan blue, and again, a complex white cataract removal. Many years later now, she presents with a dislocated IOL back complex. I removed the lens, again, using a Pac-Man technique, prolapsing the lens and capsular bag into the anterior chamber, and then cutting the single piece acrylic lens 90%, and then performing a Pac-Man explantation of the lens, performing a vitrectomy, but again, there was no vitreous in the anterior chamber throughout the entire procedure. Again, in my experience with these late dislocation situations, very limited vitreous that I noticed when I take the lenses out. And that's why I prefer to take the lenses out first in these situations, because if you do a vitrectomy, you're just going to cause the lens to fall further back and risk losing the lens. And so again, because of this, I haven't really had any experience having any problems, and it's worked very well for me. After that, I do a vitrectomy, of course, because I want to make sure that the scleral needles are clear of any vitreous. I perform my modified Yamane technique, externalizing the leading haptic through a contralateral limbal incision, performing a 25 gauge needle passive docking technique. By externalizing the leading haptic, I have better access to cannulate the right side needle with a trailing haptic much more easily. Docking the haptic on the bevel of the needle, 2 pushes is all you need. With the Sensar AR40 lens, it grips the 30 gauge thin-walled needle so much better. And then on the left side, you saw that as I passed the needle through the sclera, the AC maintainer went out, and then suddenly the globe collapsed. And of course, if the globe collapses, that means my scleral needle might not be in accurate position. Instead of proceeding and just hoping for the best, I just took the needle out, put the AC maintainer back in, held the eye contra-incisionally, with counter traction, stabbing the conjunctiva and sclera at the first mark, tunneling, staying flat to the sclera, tunneling 2 millimeters, and then diving down. You can see a well-executed Yamane technique using my modified technique, which minimizes stress on the haptics for the delicate PMA haptics of this AR40 lens. So I hope this was helpful to you, and I thank you for your attention.